Hello, my name is Laura Bachman, and I am the Chief Medical Officer for the Division of STD Prevention at the Centers for Disease Control and Prevention. Today, I will review the draft guidelines for the use of doxycycline post-exposure prophylaxis for bacterial sexually transmitted infection prevention. This document is currently posted for public comment. During the presentation today, we will review the evidence for doxycycline as post-exposure prophylaxis, or PEP, the guidelines development process. We will also review the draft guidelines and then finish up with implementation considerations and next steps. The 2021 CDC STD surveillance report documented more than 2.5 million cases of chlamydia, gonorrhea, and syphilis, representing continued increases in all of the reportable STIs in the US, a consistent trend since 2013. While anyone who has sex can get an STI, some groups are disproportionately affected, including young people, gay, bisexual, and other men who have sex with men, pregnant people, and racial ethnic minorities. There is an urgent need for new approaches to STI prevention, especially for populations disproportionately affected. Prophylaxis is not a new concept for the prevention of infectious diseases. Post-exposure prophylaxis, or PEP, involves taking a medication to prevent an infection after a possible exposure and is a common strategy for prevention of HIV and other infections. PEP is distinct from pre-exposure prophylaxis, which involves taking a medication before exposure occurs. Doxycycline, a broad-spectrum tetracycline antimicrobial, is used as pre- or post-exposure prophylaxis to prevent several different types of infections, such as malaria, for example. The French IPRGAY study was the first study to evaluate the use of doxycycline PEP. The study population was 232 HIV-negative men who have sex with men and transgender women who were 18 years or older, who reported having condomless sex with 2 or more men in the last 6 months, and were using HIV pre-exposure prophylaxis. Participants were randomized to either oral doxycycline hyclate, 200 milligrams within 24 to 72 hours of sex, up to 3 times a week, versus no medication, or the standard of care. The primary endpoint was occurrence of first bacterial STI, namely gonorrhea, chlamydia, or syphilis, during a 10-month follow-up period. The IPRGAY study found that the group that received doxycycline PEP, represented by the blue line, experienced a 47% reduction in the cumulative probability of a first STI compared to the standard of care arm, represented by the red line. When the data are broken out by STI, the reductions were specifically seen in chlamydial infection, where there was a 70% reduction in infections acquired, and syphilis, where there was a 73% reduction. There was no significant difference in gonorrhea infections between the 2 groups. Of note, gastrointestinal side effects were more commonly reported in the PEP group compared to the standard of care arm. A more recent domestic study conducted in San Francisco and Seattle examined the same research question as was studied in IPRGAY, and results were recently published in the New England Journal of Medicine. The DOXY-PEP study was a randomized, open-label clinical trial that evaluated the efficacy of doxycycline 200 milligrams taken as PEP, ideally within 24 hours, but no later than 72 hours. This was taken, or advised to be taken, after condomless sex, and the intent was for it to reduce bacterial STIs. The DOXY-PEP study was a randomized open-label clinical trial that evaluated the efficacy of doxycycline 200 milligrams taken as PEP, ideally within 24 hours, but no later than 72 hours, after condomless sex, for reducing bacterial STIs among 501 MSM and transgender women. Participants were living with HIV or on HIV PrEP, 18 years of age or older, had a history of condomless anal or oral sex with a man, and a history of gonorrhea, chlamydia, or early syphilis diagnosis in the previous 12 months. Participants underwent quarterly 3-site gonorrhea and chlamydia testing and RPR testing. Gonorrhea culture was collected before treatment. The primary endpoint was STI incidence per quarter, and this study was terminated early by the Data Safety Monitoring Board due to significant efficacy of the intervention. If we look at the proportion of quarterly visits where one or more STIs were diagnosed, significant reductions in bacterial STIs were noted in the doxycycline arms of the study in both study cohorts, with a 66% reduction in STI incidence per quarter for the PrEP cohort and a 62% reduction in the cohort of people living with HIV. Closer examination of the data stratified by specific STIs demonstrates reduction across all STIs, most dramatically for chlamydia and syphilis, where reductions range from 74 to 88% for chlamydia and 77 to 87% for syphilis. Numbers of syphilis infections diagnosed during the study were low, and reduction in syphilis incidence did not reach statistical significance in people living with HIV. Reductions in gonococcal infections were significant and ranged from 55 to 57%. 1 grade 2 laboratory abnormality and 5 grade 3 adverse events occurred that were probably related to doxycycline. No serious adverse events were attributed to doxycycline. The investigators also evaluated cultured gonococcal isolates for tetracycline resistance at baseline and then at follow-up for the standard of care arm and the doxy-PEP arms. This analysis was challenging due to the low number of gonococcal isolates. As you can see, almost a quarter of isolates were tetracycline resistant at baseline, as represented by the aqua and dark blue bars. At follow-up, tetracycline resistance was lower in the standard of care arm, but similar to baseline in the doxy-PEP arm, indicating that doxy-PEP may be less protective against gonorrhea strains with existing tetracycline resistance. Staphylococcus aureus is a bacteria carried by about 30% of people in their noses and usually does not cause harm. However, in some cases, Staph aureus can lead to infections, some of which can be serious. When study participants were cultured for Staph aureus at baseline and follow-up, there was a 14% absolute reduction in Staph aureus colonization at 12 months in the doxy-PEP arm, represented by the first 2 sets of columns to the left. However, among the staph isolated during the follow-up visits, there was an 8% absolute increase in doxycycline resistance in the doxy-PEP arm at months 6 and 12 compared to baseline. When methicillin-resistant Staph aureus was investigated, colonization at baseline was low in both groups, and there was no significant changes in colonization over time in either study arm. There was also no change in doxycycline resistance between baseline and follow-up in either study arm. Finally, the study evaluated commensal Neisseria species in the oropharynx. This group of organisms may serve as a reservoir for drug-resistant genes that can transmit to pathogenic bacteria. There were high levels of Neisseria species colonization at baseline and follow-up in both study arms, so no change in colonization was noted. Almost 2/3 of commensal Neisseria species were resistant to doxycycline at baseline, and there was no change in resistance at 12 months in the doxy-PEP arm. The next study we will discuss is the DoxyVax study. The DoxyVax study is a multi-center 2x2 factorial randomized open label superiority trial. This trial evaluated the impact of 200 milligrams of doxycycline monohydrate taken within 24 to 72 hours of sex. And the next study we will discuss is the DoxyVax study. The DoxyVax study is a multi-center 2x2 factorial randomized open label superiority trial. This trial evaluated the impact of 200 milligrams of doxycycline monohydrate taken within 24 to 72 hours of sex on time to first episode of syphilis or chlamydia among men who have sex with men with a bacterial STI in the prior 12 months. All of the individuals in this trial had been on HIV PrEP for over 6 months. This trial also assessed the impact of 4C-MenV vaccine, an FDA-approved vaccine, which some data suggest has potential efficacy against gonorrhea. And this vaccine was assessed to see if it could change the time to first episode of gonococcal infection. This trial also assessed the impact of 4C-MenV vaccine, an FDA-approved vaccine, which some data suggest has potential efficacy against gonorrhea on time to first episode of gonorrhea infection. Similar to doxypep, this study was terminated prematurely due to significant efficacy in the doxycycline group. Specifically, there was an 89% reduction in chlamydial infection and a 79% reduction in syphilis infection. What was more surprising is that there was a 51% reduction in gonococcal infection and a 45% reduction in Mycoplasma genitalium infections in the doxycycline PEP arms. Less than 1% of the study population discontinued PEP due to gastrointestinal events. Though the sample size was very small, the study found that 100% of gonococcal isolates tested at baseline were tetracycline resistant. 67 and 33% of isolates in the doxycycline PEP arm demonstrated doxycycline resistance and high-level resistance, respectively, at follow-up, versus 81% and 19% in the no PEP arm. Limited phenotypic and genotypic testing of chlamydia trachomatis strains failed to reveal significant trends in the development of resistance. Trends in methicillin-resistant Staph aureus and extended spectrum beta-lactamase E. coli colonization rates did not reveal differences by study arm. Finally, the last study we will discuss is the DPEP study. This study was an open-label randomized trial utilizing the same intervention as the previous 3 studies. It was conducted in Kisumu, Kenya, among 449 non-pregnant cisgender women taking HIV PrEP. Unfortunately, the study demonstrated benefit of doxycycline PEP for reducing incident gonorrhea, chlamydia, or syphilis. The investigators continue to evaluate potential explanations for the lack of efficacy, and early data hint that doxycycline use may have played a role. I will now walk you through the process that CDC took to develop the guidelines that we are discussing today. This slide demonstrates the basic steps in the guidelines development process that will be reviewed in more detail in subsequent slides. The first step was to identify the need for guidelines. Key questions were defined. In this case, the key questions related to the effectiveness of doxycycline post-exposure prophylaxis to prevent bacterial STIs, as well as the potential harms of prolonged intermittent doxycycline use. After the questions were defined, a systematic literature review was conducted and tables of evidence developed. The next step CDC took was to seek individual expert opinion. This took place in a multi-pronged approach. The National Association of County and City Health Officials held a 2-day consultation in December 2022, which brought together experts from the STI and infectious diseases communities, experts in antimicrobial resistance, and community stakeholders. NACHO generated a report that was reviewed by CDC. Discussions were held with individual experts, and a bioethics consultation was held to discuss considerations that should inform the guidelines and implementation plans. Subject matter experts within CDC were consulted, and the guidelines were drafted for internal and partner review. Internal CDC centers and divisions with relevant expertise and other federal partners reviewed the document and provided feedback, which was incorporated into a revision of the document. The document was submitted to CDC clearance. After it was cleared, the document was sent out to reviewers for written feedback. So we are now at the step highlighted in red where the document is posted now for public comment on the Federal Registry. Once the peer review and public comments are reviewed and considered, the document will be updated as appropriate and submitted back into CDC clearance. After the document is cleared, it will be published in the MMWR. Now we'll review the recommendation for the use of doxycycline post-exposure prophylaxis for the prevention of bacterial STIs. The current recommendation in the draft guideline document is that doxycycline 200 milligrams taken once orally within 72 hours of vaginal or anal sex should be considered for gay, bisexual, and other men who have sex with men and for transgender women with a history of at least one bacterial STI in the last 12 months. This was given an A1 recommendation. Due to lack of evidence, no recommendation can be given at this time on the use of doxycycline PEP for cisgender women, cisgender heterosexual men, transgender men, and other queer and non-binary individuals. If this intervention is offered, it should be implemented with considerations for ancillary services detailed in the document, and it will be described in subsequent slides. Men who have sex with men and transgender women who are prescribed doxycycline PEP should undergo bacterial STI screening at anatomic sites of exposure at baseline and every 3 to 6 months thereafter. HIV screening should be performed for HIV negative MSM and transgender women on HIV PrEP according to current recommendations. For individuals without HIV who are not receiving HIV PrEP, consider screening for HIV every 3 to 6 months. Doxycycline as STI PEP, when offered, should be implemented in the context of a comprehensive sexual health approach, which should include STI testing and treatment, screening for viral hepatitis, administration of vaccines as indicated, discussion of other risk reduction strategies, including HIV PrEP if the individual is HIV negative and not already on PrEP, and referral for comprehensive primary care, mental health services, substance use treatment, and other services as appropriate. Counseling is an important component of offering doxycycline PEP and should contain at a minimum the following components: a discussion of the potential benefits as well as known and unknown harms of doxycycline PEP. This could include potential side effects, such as phototoxicity, esophagitis, and esophageal discomfort, or gastrointestinal intolerance, as well as methods to mitigate side effects. Also, that should be discussed is the potential for development of antimicrobial resistance and other pathogens in commensals. It is also important to discuss the need to take doxycycline exactly as prescribed and only for its intended purposes, as well as potential drug interactions. While the use of doxycycline PEP represents an important innovation in the field of STI prevention, questions remain that should be studied. One of the first questions relates to equitable implementation. Will populations who would benefit most have access to the intervention? And how does that vary by race, ethnicity, and geographic location? What are the determinants and patterns of use of this new intervention? The randomized trials demonstrated significant reductions in bacterial STIs in the study participants, but how will this play out in the real world? What will the impact of doxycycline as PEP be on STIs at an individual, network, and population level? What will be the impact on overall antimicrobial use? Will the use of this new intervention result in an increase in antimicrobial resistance among STI and non-STI pathogens? If so, what will be the impact on the individual, network, and population levels? And what will be the impact of doxycycline PEP on the microbiome at an individual level? So while there is hope that the use of doxycycline PEP will reduce bacterial STIs, which in turn may have the benefit of reducing transmission to partners and favorably impact overall antimicrobial use, there is more work to be done. CDC has several systems already in place that will facilitate monitoring for the development of antimicrobial resistance in several key pathogens. Established in 1986, the Gonococcal Isolate Surveillance Project, or GISP, monitors U.S. antimicrobial resistance trends in gonorrhea. It is one of the longest continuously run antimicrobial resistance surveillance programs in the world. Through the collaborative effort of selected STD clinics and their local laboratories, regional laboratories, and CDC, GISP collect data that helps inform decisions regarding nationally recommended antigonococcal treatments. GISP was more recently expanded to include antimicrobial susceptibility testing of gonococcal isolates from women, as well as from pharyngeal and rectal sites. Strengthening the United States response to resistant gonorrhea, or SURGE, began in 2016 with 3 goals: enhance domestic gonorrhea surveillance and infrastructure, build capacity for rapid detection and response to resistant gonorrhea through increased culturing and local antibiotic susceptibility testing, and rapid field investigation to stop the spread of resistant infections. The project also aims to gain a better understanding of the epidemiological factors contributing to resistant gonorrhea. SURGE has increased the ability to rapidly determine antimicrobial susceptibility by using a laboratory method called the e-test. The quick turnaround time allows for rapid clinical and epidemiologic response to cases with elevated minimum inhibitory concentrations to antibiotics. More recently, the American Rescue Plan Act of 2021 provided supplemental funding for the Strengthening Hospital-Acquired Infection Antimicrobial Resistance Program Capacity Project, also known as SHARP. The goal of this program is to improve infection prevention and control activities across the U.S. public health and healthcare sectors with enhanced guidelines for directing support to local health departments. In 2022, SHARP introduced a program to ensure that some state health department laboratories had the capability of conducting gonococcal culture and gradient strip antimicrobial susceptibility testing for possible treatment failures. 16 jurisdictions listed here and shown in blue on the map are participating in the e-test component of SHARP. The sites with blue stars have completed validations and are actively testing. This program has expanded gonorrhea culture and e-test capacity to jurisdictions that do not already participate in CDC's gonorrhea surveillance programs. CDC's antimicrobial resistance laboratory networks support laboratory testing in healthcare, the community, and the environment. CDC's Antimicrobial Resistance Laboratory Network, otherwise known as the AR Lab Network, established in 2016, provides nationwide lab capacity to rapidly detect antimicrobial resistance and inform local responses to prevent its spread and protect people, closing the gap between local capabilities and the data needed to combat antimicrobial resistance in the U.S. In addition to gonorrhea, this lab network supports work on Staphylococcus aureus and Streptococcus pneumoniae, 2 pathogens that need to be monitored as doxycycline PEP is rolled out. The Emerging Infections Program is a network of 10 state health departments using public health practice to address emerging infections. Each site is a collaboration between health departments, academic institutions, and other key public health stakeholders. This program can also potentially be used to track Staph aureus and Strep pneumo infections in areas or communities where doxycycline use as STI PEP may be high. This system focuses on invasive infections, but can potentially support studies of non-invasive infections or carriage studies, and has access to medical record data to collect individual risk factor data linking to county-level antibiotic use data. Isolate collection and characterization are also part of this program. The National Healthcare Safety Network is the nation's most widely used healthcare-associated infection tracking system. This system can detect potential trends in resistance and antibiotic use for pathogens of interest. In addition, CDC is able to monitor the use of antibiotics at the county level to assess prescribing trends nationally and in selected communities. Finally, the Division of STD Prevention supports a network of sentinel STD specialty clinics that can be leveraged to monitor uptake of doxycycline PEP. 11 sites are currently funded in geographically diverse areas of the United States, as indicated on this map. So what are the next steps? Please visit regulations.com to provide written feedback. A more specific URL is in the description of this recording. In the meantime, CDC plans to develop a series of consultations with diverse groups of stakeholders to further explore the optimal way to leverage current surveillance systems to monitor the implementation of doxycycline PEP, as well as to gather information from stakeholders to inform prioritization of scientific questions and the development and implementation of future studies. The goal is to host the first consultation within 3 months after the MMWR publication. Thank you for your attention.